we are having our esteemed chairperson as Dr. Kirti ma'am, who would be joining us late, Dr. Subhashini ma'am, myself as a moderator, Dr. Shweta, and Dr. Devang, my co-moderator, along with me. So today we are lucky to have Dr. Lisa Sharmini Ahmad Tajuddin, who is going to give us a keynote address on as to how the glaucoma on the other side of the slit lamp. Just a brief introduction about Dr. Lisa. She's a professor and an ophthalmologist, lecturer in University Sains, Malaysia. Her main research area is clinical and molecular research on glaucoma, and she has more than 20 years experience in conducting different research and has completed various international, national, and university research grants. She has several publications to her in a credit in many peer-reviewed journals. She is a senior consultant and head of services for glaucoma in Hospital University Sains, Malaysia. We are lucky to have with us Dr. Lisa, who is going to just give a brief introduction, and then she will tell about on the other side of the slit lamp, what to see in a glaucoma patient. All yours, Dr. Lisa. 10 minutes.
I would like to thank the organizing committee for inviting me to this such a huge meeting. And I was so impressed with so huge exhibitor hall and also so many halls. Okay, my talk today will be on the other side of the slit lamp. All right. As we know, when we have a consultation with our patients, we are more concerned of the clinical part, IOP measurement, compliance, side effect, success of whatever the intervention is, or the progression of the disease and everything. But we often forget what are going on in the mind of our patients. They're always asking us, am I going to be blind? And they have many difficulty in their lives, such as navigation, driving, readings, and they may have not been able to go to work. They may are concerned about the payment for their treatment. They are anxious or depressed, and they often ask you, what do I do to help myself? Will my children get the disease? Although we know that one of the aim of management of glaucoma is to maintain their quality of life if we cannot improve, but only 30% of us as ophthalmologists acknowledge the needs of our own patients. Right. And we know glaucoma is a progressive disease, and once it's progressive, most likely once it becomes severe, it's at the older age group. And with the constricted visual field, no doubt will affect your quality of life. Make it either they are living in the urban, suburban, or rural area. I think the problem is the same. And on top of this glaucoma, they may also have other aging changes physiologically, like osteoarthritis, memory loss, dementia, and everything. And to top on that is they may have also concurrent systemic comorbidities like diabetic hypertension, hyperlipidemia, which is inevitably, if impossible, to get away when you age. Right. And they may also have financial issues because they are already retired at that age. And the other thing is based on the healthcare system. And I know in developing countries, healthcare system may be good, but they always often forget about the social support. And we are lucky in Asia for now that our main protective mechanism is to have extended family as a backup, because we know our social support is not good. But now I think this practice had been changed in many countries, and more of our glaucoma patients tend to live alone. And this is the pyramid of those with aging process and quality of life. At whatever age, the physiological need is still the same. And as you know, the only way to quantify quality of life for now is by using questionnaire. Either the questionnaire is based on the general vision or specific to glaucoma. The finding is still the same. As the disease progresses, the quality of life getting poorer. Mainly is in terms of navigation, reading, and also driving. And once when you have a problem with navigations and reading, you tend to be dependent to other family members. And often we know many of our patients have anxiety and depression. And based on my study in urban and suburban area in Malaysia, we have 16% of our patients who have anxiety and depression. And this number tend to be higher as compared to developed countries. So we have to do something to them to help them to actually improve their or maintain their quality of life. So with that, my team has sort of formed a study group where we call Malay Glaucoma Eye Study or MAGIS. This study had been divided into two phases, phase 1 and phase 2. We have completed the phase 1 in 2020, 3 years ago, whereby what we do in phase 1 is to identify the modifiable risk factors in terms of development and also progression of the disease. And in phase 2, whatever we have found in phase 1, we are trying to do an intervention, basically in terms of diet, exercise, navigation, reading, and conduct the randomized control trial on this. But this is still ongoing. I'll be presenting some of it in this presentation. And as I mentioned just now, navigation and mobilization is a major problems among our glaucoma patients. And many studies have found that patients with glaucoma, they walk less and slower. And as you know, we know they have a lot of domestic injury, either near fall or fall, and they are tend to bumping into the object. They have inaccurate foot placement and also disruption between the gaze and foot coordination, which play a major part in domestic injury. Right, but up until now, we know this. We have found this in so many studies, but there is no specific rehabilitation modules. Of course, there are optical devices, there are apps, but as you know, in developing country, many of our patients are not so receptive towards the optical devices and also apps. Perhaps if we could help them with occupational rehabilitation modules, maybe this in a way is the cheapest way and easiest and more friendly to our patient. So my group tried to do it by using the rehabilitation module for a stroke patient, what is known as COTNAP or Chessington Occupational Therapy Neurological Assessment Battery, whereby we just concentrate on the visual part. We are not concentrating on the motor or other parts, which is visual perception and construction activity. So in this kind of module, we have restorative method and compensative methods to come together. Basically, we look at how they scan for activities of reading, eye-hand coordination, orientation, and mobility, and also in terms of dressing, feeding, and other personal hygiene or EDL. And based on this study, excuse me, we conducted a randomized control trial. So we have 72 patients, and unfortunately, there is not much significant difference in terms of step count, physical activity, quality of life, even in terms of serum total antioxidant capacity. Perhaps this study was conducted during, lockdown, and patient may not be compliant with that. But we cannot really challenge that. So what our group think is most probably this kind of rehabilitation are not personalized enough for our glaucoma patients. So perhaps it's a good idea if we can actually conduct the first ever rehabilitation modules for our glaucoma patients. So we know we have to go into the phase 1, phase 2, and phase 3. Before that, we have to understand how do they navigate themselves. So we have conducted the phase 0, whereby a cross-sectional study was done. We use a maze, and this maze based on more of how the setting at home, and we arrange the furniture, sort of the obstacles according to the distance. So we have zone 1, whereby the distance is between 1.5 meters, zone 2, 0.5, zone 3, 0.8, and zone 4 at 1 meter. So what we found is this comprised of glaucoma patient and also the control group. We found that the glaucoma patient tends to complete the maze at a longer time, have more mobility incidents. They tend about to fall and a history of bumps. And it seems that it's inverse with the visual field parameters, meaning that the the more constricted of the visual field, the more longer time that you need to complete this maze. And among the ocular parameters, contrast sensitivity tends to be very important to determine the completion of this maze. All right. And however, we do not really study into their gaze staining, their head movement, and this will be done in the future. So we hope we whatever our finding, we'll be able to complete until we come out with a good rehabilitation module will be beneficial to our patient and also for our rehab team. Then I'm sure you have been asked by your patient, what do I do to help myself, doctors? What can I do? Can I exercise? What can I eat? What can I do further? So what kind of exercise will be good for me because I have constricted visual field? And based on the finding from our MAGIS 1, we know moderate physical activity reduces the risk and progression of glaucoma. So apart from encouraging to navigate themselves well, perhaps we have to encourage them to go out from their house and be more physically active. But the problem is how? They have constricted visual field, they are elderly, they may have arthritis. So the question is to find the best physical activity or exercise for them. So we were thinking perhaps if you go to, I'm sure you have known about chair back exercise, whereby the patient has to sit on the chair and do all the contraction of the muscles and everything, which we think is could be safe and good for that particular age group. However, based on our finding over a year of doing chair back exercise among our glaucoma patient, there is no much difference between those who are not doing it. So perhaps chair back exercise is not so good. All right, I think I'm over time. Can I just do?
Yeah, just 1 minute is there.
Okay. All right. So the other thing is secret smoking. We know secret smoking is not good for the health in general and also for cardiovascular disease. But how about the glaucoma? And what we have found is active smoking is not good for POAG, but passive smoking is a risk for PACG. I think it's more about the gender distributions. And what do you want to eat? What do I need to avoid? So there's many study, but they come out with a very inconclusive finding because I think it's affected by food preference, social culture, financial, food, and age. So what we found based on our MAGIS 1, we found that eating green leafy vegetables, cabbage, watermelon foods, marine fish, and anchovies actually reduce the risk and also the risk of progression and development of glaucoma. And coffee, for example, is increasing the risk of progression of glaucoma. Right. So in conclusion, understanding our patient needs is very important. We need to boost their confidence to be at home and also to boost them to be outside of their home. So they have to become physically active, eat healthy vegetable, fruits and fish, and reduce the consumption of coffee and tea. Perhaps one day we can come out with the list like what the heart, this brochure like, don't wait for a second attack, for example. And these are the acknowledgement of my team. Thank you. I hope we can encourage our patient to be healthy, active, and happy. Thank you.
Thank you, Dr. Lisa. Indeed, it was a very, very beautiful topic to be covered upon and a very sensitive when it comes to the management of glaucoma patients, because besides disease, it is much beyond the disease, because every time we get the patient, the first question they ask, okay, what was our mistake that we got this glaucoma, and now how to combat with the challenges of the life. So I think that was a beautiful insight in the whole scenario of how to combating with the challenges when the patient is having a disease. And with that, we move on to the second speaker, the first speaker for today's session. That is Dr. Preeti ma'am, who is going to again deal with the one of the most challenging topic in the fields of glaucoma, that's assessing a glaucoma progression. So let's see that what are the clinical pearls.
Just a minute.
So in the meantime, if you have any questions, you can ask. Otherwise, we'll take the questions at the end of the session. So always in glaucoma, as we say, that the counseling matters a lot. So whenever you are dealing with a glaucoma patient, be little empathic towards the patient. Spare some 5 minutes extra as you spare for your other normal patients. Because in glaucoma, when you teach the patient about the lifestyle changes he needs to do, definitely in long run, it is going to benefit you and your patient as well.
Yes, rightly said, Shweta. I think what
what have been taught to us from, from our seniors, from all the stalwarts, what they say is never treat the eye, treat the patient in whole. I think that's what is important.
ठीक है, कोई बात नहीं, ऐसे तो नहीं होना चाहिए।
उनका भी हाँ,
Anyway,
बस करेंगे, उनका भी एक्चुअली नेक्स्ट उसमें उनका ऑलरेडी चल रहा है।
नहीं, डिजाइन का कोई प्रॉब्लम नहीं, स्लाइड शो नहीं जाता।
अमित को एक बार फोन कर
हाँ,
चुकी।
प्रेजेंटर में ठीक है, चलिए उधर से आपका कुछ करना पड़ेगा। चलो, कोई बात नहीं। Yes, thank you. So, good afternoon, everyone. And diagnosing progression is a challenge you accept when you treat even one patient of glaucoma, and more so when you choose glaucoma as your subspecialty. It's easier to diagnose glaucoma, but it's difficult to diagnose progression. It's a 6-minute talk. This will be just a general overview and not a detailed one. So, how do you diagnose progression? You have to have a certain plan. And just a minute, I will. You have a pointer?
No, ma'am.
Laser pointer, please.
Yeah. So it involves surveillance planning, data collection, analysis. Yeah. And because glaucoma is a slow, chronic, silent disease, and regular follow-up is the backbone of assessing efficacy of treatment, that is progression. And that is one thing at diagnosis you have to sort of drill it into the patient's head by repeating it again and again and again. And it involves 4 steps: surveillance planning, data collection, analysis, and interpretation. So, what is surveillance planning? How often should be the follow-up? How often should we do the tests? So, higher IOP, advanced field damage, younger age, positive and severe family history warrant closer follow-up and more number of tests. So progression can be detected only and only if you know what you started with. So if you want to know if I'm worsening, you have to know what you began with. So establish a good baseline, and that's the first principle of diagnosing progression. So what do you mean by establishing a baseline? The challenge is there is no single test which on its own can diagnose progression. And so the baseline is established with functional tests like perimetry and structural tests like disc photographs, OCT. Mind you, I am writing OCT as the last. OCT. Each has a different sensitivity across the glaucoma spectrum. In an advanced glaucoma, OCT is useless. Perimetry is across the glaucoma spectrum. Perimetry is the test to do, and so if your patient can afford only one test, it should be perimetry. All right. So another challenge for me in private practice is getting patients to do all these tests, because they are charged and they're required to do it every 6 months, and that takes an extraordinary ordinary amount of counseling, but it has to be done. That's part of your job. Okay. So how do we analyze? So we have collected data. I have told you how often to collect the data. How do we analyze? The analysis can be either manual and with statistical support, and in most cases we use both. So how do you analyze? The simplest method of detecting disc change is serially examining photographs. This is one lady who in 2015 had these nerve fiber layer defect, which has not really translated into disc damage. 2017, you can see it a little bit more clearly, and in 2020 you see it has enlarged. So this is progression on disc. You don't know who's going to progress, so it should be done as a discipline in every glaucoma patient. That's one thing. Now this, and as I said, it's a discipline because I didn't know she was going to progress. 2015 to 2020, it has taken 5 years for her to progress. OCT, when you have fewer scans, you eyeball the scans. But if you want to say that OCT is a very precise machine, this superiotemporal quadrant 129 is the measurement. After 6 months it became 137. After another 6 months it's 124. So fluctuation is part and parcel of any machine, even OCT, which is claimed to be very sensitive. And then how much change is significant? It is said 5 to 7 microns because that's the resolution of this machine, but this tells you that no, you can have much larger fluctuation even when even with OCT. If once you have enough number of tests, then you have this kind of a guided progression analysis, and it is you have 3 scans. The baseline tests are compared to the tests here, and you have various graphs which show here it's obvious even on just eyeballing it, and plus the graph also shows progression. Perimetry is the mainstay of diagnosing progression across the grades of glaucoma severity. Again, for the first 2 to 3 fields, one has to eyeball the fields. A large proportion of the tests from a single field test will give you false positives, and hence the CNGT, the collaborative normal tension glaucoma study, suggested that one confirmatory test is not sufficient. False positives will still exist, and hence you should have 2 fields, and therefore clinicians should obtain a second and or also a third field. And here you will see in the guided progression, the glaucoma progression analysis, the fluctuations are higher with damaged areas and fluctuations are a norm. In fields with very highly damaged field like this, 10-2 is mandatory. It gives you more to play with, and there is no statistical support. The statistical support is only for mildly and moderately damaged spots, and here it's when it's you and your experience, and it's just for my colleagues that it's very difficult to diagnose progression in advanced glaucoma. So it would be better if you're treating such a patient, at least have one opinion from your glaucoma colleague, and that will really help you. So in DISC, how do you interpret? Just 1 minute. I think I've exhausted 6 minutes, just 1 minute.
Oh, no problem.
Yeah. So interpretation is correlating all the data with the clinical picture, the complete clinical picture, including the intraocular pressure and all the other things that you've been doing, and the vision. So sometimes it's very easy. Now this is one patient, 3840, high disc damage. This is in 2011, right eye, left eye. 2019 he comes back, one eye no PL and the other eye such an advanced field. This is very easy. You don't require to really think too much, and it's easy. Now, when one test shows progression and other does not, then what do you do? For example, in this patient, the intraocular pressure was normal, perimetry is normal across 5 years, but the OCT definitely shows progression. So now is the dilemma. Do you treat it as glaucoma? Do you treat it as just observe? The answer depends on the clinical picture. If the intraocular pressure remains high, one might consider it as progression. But to date, most of us glaucoma guys, we rely more on disc photographs. Perimetry is considered the hallmark. So maybe you may alter treatment based on this, but you may not make surgical decisions based on just OCT progression. So the challenges again are, there is no single test which tells you progression, multiple tests to be repeated periodically as a discipline, test retest variability across all modalities, and all tests do not concur always. And that's when perimetry disc photographs take precedence over OCT. Convincing patients to undergo these tests has been a challenge in my practice. And thank you all for a very patient listening.
Thank you, ma'am. Indeed, it was a very beautiful presentation and giving us so much of courage that how to face the challenge, accept the challenge, and diagnose the challenge. With that, we come up with the next speaker of the session. That's Dr. Devang, who is going to talk about the fixed dose combination in IOP control, a path-breaking initiative. Any questions from the audience? If not so, I would request the second speaker to be ready with the presentation. And I would request all the speakers to please stick to the time so that we can hand over the hall to the next session people. So whenever we talk about progression, the clinical pearl would be never comment and confirm progression on a single field's OCT or anything, whichever you think that it's progressing. Always reassure, reconfirm by repeated test. over a short period of interval, and then you say, because once you say progression, that means you land up adding the medicines or taking a decision for surgery. So we'll start the presentation for Dr. Devang.
Okay, thank you, Shweta. At the outset, I would like to greet a very good afternoon to everyone. And I would be speaking on fixed dose combination in IOP control, a path breaking initiative. So as we all know that glaucoma is the leading cause of irreversible blindness, and the global daily, that is the disability adjusted life years due to glaucoma, has increased by nearly 81% from 1990 to 2017. And in India there are 12 million people who are affected, and nearly 1.2 million are blind due to glaucoma. So in glaucoma, medical therapy is the most frequently used intervention for lowering IOP and is typically the first line therapy in most of our patients. And combination of agents are often therefore required to achieve and maintain the target IOP. And intensive combination treatment leads to considerably greater IOP reduction and prevent the disease progression. And if you look into IOP control, so uncontrolled IOP is a key risk factor for development and progression of glaucomatous optic neuropathy. And even 1 millimeters of mercury decrease in IOP reduces the risk of progression by 10 to 20%. And it has been put up by various landmark studies. If you look at the treatment non-adherence percentage, it is a major concern in India. Nearly 50% of the patients do not adhere to their medications over 75% of the time. And increasing the number of daily installations reduces the ability of the patients to adhere to prescribed therapy. Also, a complex therapeutic regimen are associated with additional side effects due to the preservative that is involved with each drop that is instilled. And when 2 drops are instilled too close in time, the application of the second drug may reduce the effect of the first drug. And therefore, simplifying drop regimens may be beneficial to improve the patient's satisfaction and adherence. So, the various guidelines like NICE, EGS, CGEG, Asia Pacific, GSI, all of these guidelines recommend the use of combination therapy for the management of glaucoma. So one of the screenshots from these guidelines are when, especially for patients who are progressing, who are in advanced glaucoma, that you start with 1 drug at a time and then you start increasing the drugs. And if the target IOP is not achieved, you switch on to 2 bottles, you switch on to 3 bottles, and when it is still not controlled, you switch on to surgical measures. So what is maximal medical therapy? Maximal medical therapy is the use of 3 or more different classes of anti-glaucoma agents to achieve a maximal lowering of IOP. MMT attempts to achieve the best possible therapeutic outcome with medications while minimizing the adverse effects and compliance challenges to the patients. And availability of 3 or more different classes of drugs as a single FDC helps to achieve a simplified installation regimen and thereby increasing the adherence. So we again reiterate the issue of with multiple medication usage is that there is a compliance or adherence issue, and also there is increased side effect because of the increased preservative exposure. And FDC eye drop significantly improves the adherence in these patients who have a poor history of adherence, who have burdensome multiple installation of drops. And if you look at the side effect profile of this multi-drug therapy, preservatives used in the topical glaucoma medications have toxic effects on the ocular surface. One, long term, if you look at the long term use of topical drugs, they do have local side effects like hyperemia, redness, tear film instability, stinging, burning, and dryness. And it's a very chronic problem that we all glaucomatologists face, because whenever the patients come for follow-up, they'll always say this, and we again have to counsel that, you know, the drug is acting, you have to use it, otherwise it'll lead to irreversible blindness. And thirdly, the prevalence of ocular surface disease, it is estimated to increase by 50% in glaucoma patients under multiple medication therapy. Also, the incidence of toxicity can be mitigated by decreased preservative exposure. So if you look at, we all know that in multi-drug therapy, we know that double drug is there and we are widely using. But if you look into the world literature, there is very limited study on triple drug therapy. So few studies have shown, like beta blocker with brimonidine and dorzolamide has come, and one on bimatoprost, brimonidine and timolol has also come, but we don't have large studies on it. We don't have a long, what is the side effect profile, what is the IOP lowering effect. There is no major study on these. So what is one good thing is that recently a triple drug combination has been developed in India for glaucoma, and the clinical trials and ocular toxicology studies have been conducted with this triple drug FDC. So what is the rationale, or what is the advantage of the triple drug FDC is that there is a reduction in the total number of drops and preservatives instilled per day. There is improving the compliance of the patient. It avoids the washout effect resulting from rapid sequence installation of multiple drops. It reduces the risk factors of ocular surface damage because of the preservative exposure, the cost benefit to the patient, which is an important thing in our part of the world, and ease of adding an additional class of anti-glaucoma drugs whenever required. So at the end, I would like to say that we should all initiate with the monotherapy and build on to polytherapy. And simplifying drop regimen is beneficial in improving patients' adherence, reducing the side effects, and improving patient satisfaction. Ultimately, all of us is fighting against this big invisible glaucoma, the root cause of this irreversible blindness. And let's join hands to fight against this disease. Thank you.
Thank you, Dr. Devang, for that introduction and telling the details about that. What is the advantage of using the fixed dose combination? And with that, we move ahead with the next speaker for us. That's Dr. Subhashini ma'am, who is going to talk about ocular hypertension, the way forward. Dr. Dilip, presentation uploaded, hai na?
Your presentation already. Okay. Which one? This one. Third? Yeah.
Good afternoon, everyone. Thanks, Shweta. So my topic is on ocular hypertension, the way forward. We all know the definition of OHT. It's IOP more than 2 standard deviation from the mean of a normal adult population with normal fields and no evidence of optic disc changes. However, studies, they differ in the definition of what is normal fields and normal optic disc structure. We need to have a thorough understanding of the evidence-based risk factors. There are a lot of questions that come to mind. So which are the risk factors which play a role in decision whether to treat a given patient with OHT? How do we synthesize a patient's risk factor profile into a recommendation on treatment? And does delaying the treatment of OHT matter? There are several other questions. The OATS study tried to answer most of these. The OATS phase 1 study, actually, it was a proof of concept, and to know whether medication would delay the progression of OHT, conversion of OHT to POAG. And it was also to determine the major clinical and demographic factors that would predict which patients would develop POAG. Then the OATS phase 2 study was an extension of the OATS 1 study. The OATS 1 was over 7.5 years, and this was another 5.5 years. And this was, the patients who were randomized to the treatment group in the OATS 1 were continued the treatment and followed up, and the patients who were randomized to the observation group were started on treatment. That's the OATS 2, and the objectives were to find the cumulative incidence of POAG in the delayed treatment group, and also the subsequent course after diagnosis, whether it's worse in the delayed treatment group. Then there's the third phase of the OATS study. The objectives were to determine the incidence and severity of POAG in the cohort, and also one objective was to find to develop a 20-year predictive model, so which would assess the previous factors as well as identify new risk factors. We all know the results of the OATS 1 study. The ocular hypotensive agents, in fact, reduce the risk of progression of OHT to POAG from 9.5% in the untreated subjects to 4.4% in the treated subjects over the period of 5 years. And they also found out 5 major risk factors in their prediction model. So one was the age, the IOP, second IOP, third was the vertical cup disc ratio, fourth the pattern standard deviation, and then the fifth is the CCT. In fact, CCT was considered a strong predictive factor, and the risk was 3.4 times more risk for progression to POAG when the CCT was less than 555 microns. And the OATS-2 results was that the cumulative proportion of POAG development was 0.22 in the untreated cohort compared to 0.16 in the treated cohort. And they also found that the absolute effect of early treatment in decreasing POAG incidence was greatest for the high-risk OHT. This number is very important, number needed to treat. So this means for every patient that is prevented from developing glaucoma, how many patients need to be treated to prevent one person of OHT getting converted into glaucoma. So Cass, the lead investigator, and his colleagues, they stratified into based on the risk into low risk, moderate risk, and high risk. And this number needed to treat was 98 for the low risk group. So 98 patients in OHT have to be treated to prevent one person from developing POAG. So in the moderate risk group, this NNT was 16, and in the high risk, it was 7. These risk calculators actually are a good starting point to help us decide which OHT patients need treatment. So this is based on that 5-factor predictive model of the OATS study. To initiate treatment, so when you calculate the risk, this risk based on these 5 factors, if the 5-year risk was more than 35%, or then 35 or more than 35, then you can consider treatment. An important thing to note is some of the important risk factors like myopia, race, cardiovascular disease, family history of glaucoma, diabetes. So these were not considered as risk factors in the prediction model of OATS. Especially diabetes gave very inconclusive results. So what is the way forward? The approach to management, that is when to treat and when to monitor, would depend. So a good way is would be based on stratifying them into high risk, moderate risk, and low risk. Majority of the patients fall in the low risk group. So because of so they so they require just monitoring at less frequent intervals, once in 2 years. So those in the moderate risk group can be monitored at frequent intervals, and treatment is withheld until damage is documented. Whereas in the high risk, you can consider treatment. All these risk stratification is based on the RNFL changes, the intraocular pressure, and the CCT, and the vertical cup disc ratio. So what would be the target IOP once you decide to treat? A reasonable aim would be a 20% reduction. And what treatment to choose would be, you can start off with medication, or even SLT you can consider as a primary treatment, and surgery in the form of TRAB, or now MIGS techniques available, you can choose that. So in summary, ultimately the decision whether or not to initiate treatment is the patient's. So this is the most important thing. And there is a continued need for pragmatic RCTs and cost effectiveness studies using realistic everyday data. Thank you.
Thank you, ma'am. So we call upon our next speaker, Dr. Dilip sir, who is going to concisely give us a nutshell about the diagnostic armamentarium of glaucoma. And till he is taking his dais, I would like to ask ma'am one question. Ma'am, what is your one clinical pearl which you would like to share with the people here, that how do they start treatment about the OHT? Any one clinical pearl, like what is your deciding factor to start a treatment? Ma'am, come here. Ma'am, come here. Chairperson.
As I showed in my presentation, so there is I can't say it's a single as a single factor which decides. But as I said, when you consider all the risk factors, but the if at all, the most important would be you explain all this to the patient, and patient decides.
patient decides whether he or she wants the treatment or not. So you can put all the facts in front of the person, and then it's the patient's preference finally at the end, because we have seen the risk factor profile based on that. So if there's a high risk, but invariably in India they always leave it to the doctor to decide. You decide. So in that case, you go by the stratification based on all the risk factors. If they're high risk, there's no chance. If the IOP is 26 or more, intraocular pressure 26 or more, you have to treat whatever be it, even if the cupping and fields are normal. If the IOP is in that range of 21 to 25, then you have to go by the other factors and decide.
Thank you, ma'am. So,
yours. So, good afternoon. Today is my talk on the unraveling the diagnostic armamentarium of glaucoma. So, there is no financial interest. So, nowadays in glaucoma, we have too many choices. In all these techniques, we are sometimes confused what to do. So, let us take one by one. There is a lot of dynamism in diagnostic armamentarium, starting from IOP measurements to CCT measurement, anti-chamber angle measurement, optic nerve assessment. So one by one we will take, and first IOP measurement. Goldman applanation is the still gold standard, but lot of new technologies like eye care rebound tonometer is better tolerated than Goldman. No anesthesia is required, and nowadays lot of refractive surgeries are going on. So we need a corneal thickness independent tonometry like this dynamic contour tonometry, and DCT data we are flat across the spectrum of corneal thickness reading, unlike the Goldman applanation. So this DCT is least affected by refractive surgeries. Next one is the ocular response analyzer. It is based on corneal hysteresis and can be used a risk factor for development and progression for glaucoma. And this ORA gives data about the GAD correlated IOP, corneal compensated IOP, and corneal resistance factor. So next comes the anti-chamber angle assessment, gonioscopy, and lots of other amazing techniques. So first take gonioscopy, indirect one is the most common. It will give us about the angle measurement, grading, about iris configuration and roots, any deposit, synechies, pigments, new vessels, or if any nodules is there. So gonioscopy is the most critical instrument. We have to give 2-minute time in our busy OPD procedure, OPD time. We are doing OCT and a lot of imaging, but we are not taking time of 2 minutes for this Goldman. So it will give us idea about it is open angle or close angle. Next comes the various imaging technique in anterior segment. This is ASOCT and UBM. So anterior segment OCT has a lot of application. It will give high resolution and screening for angle closure. It will give blab imaging and position of tube in shunt surgery. It will do pachymetry, and we can assess the effect of PI or tube, and also useful in malignant glaucoma and plateau iris detection. ASOCT has a non-contact and no indentation method, shorter imaging time, and is highly reproducible and easily documented, but it is limited only to anterior to iris. It is unable to penetrate iris and ciliary body zonule not clear. So there comes ultrasound biomicroscopy. It images all angle component posterior to iris also. It images iris ciliary body complex, and it is also possible to study the behavior of iris and angle under various conditions. As compared to ASOCT, it is a high resolution. So UBM is very crucial to detect the functional status of filtering surgery, malignant glaucoma, and pigment dispersion syndrome. You can easily watch the typical posterior bowing of peripheral iris. Next one is a pentacam, is the only good screening tool for antechamber volume and dynamics. And limitation is difficult angle assessment as no direct angle visualization. Next comes the optical assessment. We can do with a slit lamp with the help of 90D or 78 diopter, and it will give a good stereoscopic view and can detect early RNFL defect. You can take photography also by stereoscopic methods. It used to document structural abnormalities, and it is highly reproducible and record a natural color or image of the retina. Next is the quantitative imaging. We have OCT, HRT, and GDX. All three has a different principles. So have a look on this all three. You can see that optical coherence tomography is a strong has a strong assessment of RNFL and ONH. It is a very versatile instrument, and very highly specific. 90% specificity is there in a OCT, but less reliable on poor signals. Otherwise, GDX and HRT are observer dependent and image quality are lowest in the GDX. So we prefer usually in the OCT. Apart from OCT, RNFL should not be interested in a macula GCC scan, ganglion cell complex scan, because 50% of retinal ganglion cell are found in the macular region. These are the normal macular scan. Therefore, measurement of this GCC is more effective than evaluating RNFL alone in diagnosing early glaucoma. Next comes the OCT angiography. OCTA is a routine test of future. So if we combine OCTA plus OCT RNFL, it will be a powerful diagnostic tool. Peripapillary, optic disc, and macular OCTA parameters show a stronger functional association with visual field. Very accurate in advanced myopia, advanced glaucoma, myopia, and atypical optic nerve head. But it lacks normative database, motion artifact, and observer dependent. Lot of future imaging techniques are developing in this scenario. Last but not least, the visual field assessment, that is the functional assessment, is a very must. So 24-2 and 32- is a method of choice, but many times this 24-2 misses defects which will be detectable on 10-2, and 10-2 is a good choice when relating GCC functional damage to structural changes, especially early glaucoma, OHT, and suspects. Virtual perimetry is also coming and very promising, but it unable to defect that match standard automated perimetry and unable to demonstrate ability in early to moderate glaucoma. So lastly,
Dr. Dilip, can you just wind up quickly?
Last slide.
Yeah.
This is we have, if mixed clinical acumen plus testing, that it will give a good results. So we have forgotten clinical skill, which works very well when our OCT machine does not work. So diagnostic testing are complement to good clinical skill, not a substitute. And interpretation should be taken cautiously after the correlation with the structure and function. And serial OCT scans are useful in diagnosing early glaucoma that may fall under periperimetric glaucoma. Thanks for listening.
Thank you, Dr. Dilip Lalwani. That was a good overview of all the diagnostic tests in glaucoma. Now we'll move on to the last talk by Dr. Shweta Tripathi. She would be speaking on compliance conundrum of the AGMs. Over to you.
Yeah, a very good afternoon to all, and thank you AIOS for giving me this opportunity. I cannot see my presentation. Dr. Shweta Tripathi.
Any questions from the audience? You can please put forth. So in the diagnostic tests that was all mentioned, so, OCT plays an important role, and as Dr. Dilip said, we need to consider clinical skills too. So you can't simply overlay on your whatever diagnostic tests show, because all imaging devices have their pitfalls. So you should know those. So it's not a substitute for your clinical skills. Yes, please ask.
Just like to give a comment. I'm not an ophthalmologist. I'm a clinical geneticist. But I'd just like to give to respond to the comment you made about patient. Patient is the decider of they make the final decision. So I think I fully agree with that. I think that is the basic principle of giving counseling to a patient. I think we give all the information, provide all the information to patients, and they make the final decision, they inform consent. And I think it's similar. I'm from Malaysia, and I think the situation is similar in Malaysia. Normally, patients tend to ask the doctor, to decide for them.
Yes,
and I
yes.
think we should avoid that. I think the message is that we should always avoid to decide for the patient, because, well, if anything goes wrong, the patient may turn around and blame the doctor. But I think that is against the basic principle of counseling. We should always avoid to make decision for the patient. It's a
Yes,
comment
yes,
for me.
correct. You need to spend that extra 1 minute to explain to them and then let them take the decision. Thank you.
Thank
Over
you.
to you.
So, a very good afternoon to all. And today we are going to cover a very important topic when it comes to the field of glaucoma management. Talking about the compliance, we all know that the prevalence, when we talk about India, it's about 11.2 million, covering all the different types of glaucoma. The basic challenge when we face about glaucoma diagnostic is whether it's going about the underdiagnosis or a late diagnosis or a overtreatment. But everything comes down to the same point. That's how do the patient is complying or adhering to the treatment. So let's talk about the compliance or the adherence. So there was a study, different studies, which said that the main cause for the patient non-compliant or non-adherent was lack of knowledge about the disease, lack of like ignorance led to the poor health seeking behavior, awareness, everything was lapping. So we as a treating glaucoma people do have an additional responsibility of making our patient more compliant, adherent and persistent. So why do we need to address this compliance so much when it comes to glaucoma treatment? Does it really affect the treatment protocol? And the answer to that comes definitely a big yes. Why? Because when we know that the glaucoma treatment is a lifelong therapy, which might lead to an unnecessary burden on the pocket, compromise the quality of the life. So an unhappy patient leads to an unhappy doctor as well. So definitely none of us wants to be unhappy. It leads to unnecessary decision making of investigation or a surgery. Simplifying the terminology, there's a difference between a compliance and an adherence. Compliance is a one-way procedure, like you tell the patient has to comply by it. And adherence is that the patient is a two-way, bi-directional process. You tell the patient, make a patient part of the treatment regime, and then you say, okay, this is the treatment strategy, and the patient has to adhere to it. So basically from here onwards, we are going to use the term adherence. So now, because we all know the treatment of the goal of the treatment is definitely not only about reducing the IOP, it's about giving the patient a good quality of life as well. So there are certain questions which we should keep in our mind before starting the glaucoma therapy. That if the patient is for the first time a glaucoma patient, definitely you need to spare some more time for that particular patient. If the patient is taking more than one glaucoma medication, they need a combination therapy. Any systemic medication they are taking, because we know that the systemic and the topical antihypertensives, they do have some interference to with the action of each other. Allergy about, especially about the alpha agonist or sulfa allergies. The ease of administration, because squeezing a bottle would not sound a big task to us, but just think about a patient who is having a problem with the dexterity, or elderly patient. Squeezing that bottle means a lot to that particular patient. The patient's use of contact lens, and the patient is pregnant or breastfeeding. So with the different dimensions of adherence, again, this was a further study which said that the most common cause of the patient being non-adherent was the side effect or the lack of awareness. So if we want to divide this non-adherence, we can broadly divide it into two categories. One would be the unintentional, that's the practical barrier, or the intentional, that is the perceptual barrier. So if we talk about the practical barriers, most of them we have covered already. That's the complexity of the regime, the cognitive barriers, the physical barriers, the patient education, and the patient lifestyle. Because we cannot imagine a company CEO putting a drop thrice throughout the day. So you have to titrate according to the patient's need. It is not a rule of thumb that for everybody you have to just give thrice BD or HS drug. You have to just titrate, keeping the patient's lifestyle in your mind. So the most important point what we face in glaucoma is the communication difficulty between the patient and the physician. So that is what I've been emphasizing from the very beginning of this session. Please try to spare some extra minutes for your glaucoma patients. Talking about the unintentional non-adherence would be that what are you going to do in that particular, I can say the objectives, how you can overcome them. Provide a verbal information, online video, written information. Regime has to be titrated. The bottles, the labeling can be done on the bottles, or for the patients who are having dexterity problems, the dose administration aids are there. Always teach your patient about the punctal occlusion. That's really important, which will reduce the systemic absorption, and definitely that is going to give a higher efficacy of the drug. Talking about the intentional non-adherence, educate your patient not only about the disease, it's about the drug side effect. And you tell the patient, because in any eye treatment or any treatment, the common belief is that you take the treatment, the benefit is there. But in glaucoma, actually it is not the patient who is going to get the difference in the treatment, what is going to gain out of it. It is us who is going to teach the patient that every time you come to us, we are telling you that you are progressing or the disease is stable. So the need of the eye is definitely going to be keeping a balance between the concern and the necessity. And the concern for glaucoma patients are side effects, disruption of the daily activities, or the glaucoma is asymptomatic in nature, so it's not giving anything. I'm sure that none of us wants our patients to be like this. So definitely we have to tell the patients, warn the patients about the side effects already. Then we have to take care of the preservatives. And in all, I can just summarize saying that early detection, assessment, strategy, and education. And last but not the least would be the follow-up with reassurance will definitely lead to with a healthy and a happy patient along with a happy doctor. Thank you very much.
Thank you, Dr. Shweta, for that wonderful insight into the compliance issues. Any questions from the audience? Okay, yeah.